Good morning, everybody. The structure of my talk this morning is to try and get you awake and interactive a little bit. So the first 10 slides or so are case vignettes. And after that, we'll get into the talk proper. And I do welcome feedback during the case vignette, so I am expecting some comments. So we'll start with the cases, move on to prognostication in kidney disease, symptoms and signs of the patient who's declining, the end-of-life patient with end-stage kidney disease, and then look at the renal palliative care interface. So we'll start off with one of the first cases. And I see Siobhan and Dr. Higgins in the audience, and actually they probably have been involved with a lot of these cases, so they may have some comments to make as well. The first patient is a 77-year-old male who's been on hemodialysis through an AV fistula since 2009. His background was of radical cystic prostatectomy, which was complicated by bowel obstruction, ileal conduit, and he has a high output ileostomy, which has actually made dialysis quite challenging in terms of electrolyte and fluid balance. He developed persistent hypotension on dialysis, and he actually required IV fluids through most of his dialysis sessions, fludrocortisone and midodrine to try and maintain a normal blood pressure. He was a bit of a divil of a patient. There were a number of times when he presented to the emergency department unable to walk because of persistent hyperkalemia. And when we spoke to him, he's actually a polytunnel enthusiast. I didn't know what a polytunnel was until I spoke to him. And he grew huge quantities of tomatoes. So tomatoes are very high in potassium. And he would eat cherry tomatoes by the handful and then come in with paralysis at least twice a month. And if it wasn't cherry tomatoes, it was whiskey, which is also very high in potassium. So, I mean, the reason I tell you this is that actually he had a fantastic quality of life, despite the fact that he was on hemodialysis. He was heavily into gardening, and he was also quite a good ironmonger and made gates for several of the dialysis patients and nurses in the unit. So in terms of his contact with us, apart from his admissions to hospital with hyperkalemia, we used to have to change his perm cath maybe twice a year for infection. Then in February of 2016, he had an acute occipital infarct, and he lost vision in sort of half of his visual fields, and that meant that he could no longer drive and he could no longer practice his ironmongery. So that's a significant event for him. A little later that year, he was admitted to the intensive care unit with a major GI bleed requiring embolization of his jejunal arteries. But actually he recovered extremely well, was discharged home, and although he couldn't drive anymore, he was still able to potter around the house and tend to his garden. He was readmitted a year or so later with a new painful vasculitic rash on both of his legs. The biopsy was consistent with a condition called calciphylaxis, which is also called calcific uremic arteriolopathy, which is essentially where when you've been on dialysis for a long time, you deposit calcium in the media of the blood vessels, and the blood vessels, the area supplied with them starts to infarct. Classically affects hands and feet, but can also affect the trunk. He presented to us on several dialysis sessions in severe pain, and we admitted him during one of the sessions. He became bedbound really within 1 week of admission. We had challenges around nutrition, and his ulcers became infected. And hypotension on hemodialysis was a major issue. So I guess what I'd like you to throw out at me is there anything else you want to know about this patient? At this point, or maybe earlier in his clinical case or course, could you have predicted his likely outcome, and were there any warning signs within the previous year? Would you be surprised if he died within the next year? I mean, some of you would be surprised, I guess, if he was alive within a month. And then how should we progress this man's care? So I'm going to throw back to the audience to give me some, feedback as to, what we did with this man maybe in the final weeks of his life, or what you would recommend that we do. So I hope you're not a quiet audience. Now there's a 30-second rule, and I'll count to 30 and wait for somebody to say something.
Did he ever talk about prognostication himself, or his family?
His patient wishes? Yeah.
Or prognostication or
Okay, so that's a really good point. And I think when I go to to the rest of the talk, you'll realise that actually prognostication in end-stage kidney disease can be quite difficult. We don't have any particularly good prognostic tools. You know, there are some reasonably good clinical clues. Anyone who develops anything involving circulation, so peripheral arterial disease, hypoalbuminemia, frailty, recurrent falls, hypotension on dialysis, they are the classic bad markers if you're looking at predicting how somebody is going to come or how to do. So in reality, we would have recognised as soon as he developed the first ulcer on his hand that this was probably him entering his terminal phase. We liaised with his family very rapidly. We admitted him for pain control, but also to give his family some respite and engage our palliative care services, who probably would have been seeing him as soon as his first ulcer developed and as soon as pain became an issue. We had frank discussions with both he and his family around the appropriateness of continuing renal replacement therapy. So dialysis was withdrawn with his consent and with his family's consent, and he died about a week later with us, actually. And again, the interesting thing is that he elected to stay with us, and many of our patients don't want to go to the hospice. And it's not because the hospice has a bad reputation, it's because we have provided so much care for them for such a long time that we're like their family. So actually you'll find that a lot of our patients choose to stay with us. Okay, so second case. This is a 52-year-old woman who was referred initially in 2011, and I mostly saw her in outpatients. She had a seizure disorder, very significant autistic traits, chronic kidney disease probably due to lithium use for her bipolar disorder, moderate intellectual disability, and had been in residential care since the age of 14. An incredibly supportive care environment. So every time she came to see me in clinic, 2 of her carers came with her and 1 of her 4 siblings came. So everybody was really invested in this woman's care. She didn't have capacity to understand her consent to treatment, but she had things that she really enjoyed. She enjoyed music, she enjoyed Coke, she enjoyed weekend visits to her sister. So these were the 3 things that were really important to her. The outpatient visits were challenging. She screamed repeatedly during the consultation, and whenever we touched her to do her blood pressure or examine her, and she engaged in a lot of repetitive movements which indicated that she was very stressed during the outpatients. So this graph just shows her creatinine going up. So basically, by the time we come to the end of the graph, this is where you would be considering starting somebody on renal replacement therapy. And about 2/3 of the way along, you would be having discussions about management. So again, my questions to you: how should this patient be cared for? What treatment options would you propose? I know you're not nephrologists, but you know, would you offer dialysis? Ethically, is she a transplant candidate? And if end-of-life care becomes appropriate, if we decide not to deliver renal replacement therapy, where should that end-of-life care be delivered? So this is a fairly interesting case. It was very tricky. It required a lot of thought on my part and on the multidisciplinary team's part. So again, any comments or any thoughts about what we would do with this young woman? Well, middle-aged woman. Would you offer her dialysis?
Looks like she can't even tolerate blood pressure.
Okay, so I don't know how much you know about dialysis, but you know, hemodialysis is I suppose there is an intervention required. You have a catheter coming out of, there was no way she was ever going to manage an AV fistula because you'd be coming at her with needles 3 times a week. But if she had a tunneled catheter, it's a possibility, but you would be concerned that that catheter would be pulled out. And could she lie still for 3 or 4 hours to receive the treatment? And would she want to? Then you have options around peritoneal dialysis. Again, it requires a tube, but it could be delivered by her carers in her care home, so you wouldn't be taking her out of her care environment. But again, would she tolerate the procedure? And would she tolerate somebody manipulating a tube maybe 3 or 4 times a day? Or would she stay in bed for long enough at night time to tolerate nighttime dialysis? So what we did do was we had a multidisciplinary care planning meeting, and it was the longest multidisciplinary care planning meeting of my life. And it went on for 2 hours. Now you might think that's nothing, but actually it was incredibly intense. We had her 7 siblings in the room, our multidisciplinary team, and the 3 carers who looked after her most in her care home, the consensus that was reached was that she wouldn't be for renal replacement therapy. We all viewed it as an extraordinary measure to prolong life. We had concerns around her ability to comply, concerns around how it would impact on her quality of life. We spent a long time talking about transplant ethics. And my own view was that unless one of her siblings was going to be a transplant donor, that I didn't think that cadaveric transplantation to prolong life was reasonable. And we also talked about assisted PD and its feasibility. We also made a plan for future care, so we really streamlined her outpatient follow-up. I had a very pragmatic approach to her diet, which was I didn't care what she ate or drank as long as she was happy. We completely rationalised her meds in terms of things that were not necessary, so she didn't have to take them. And when her uremic symptoms became apparent, we stopped bringing her to the hospital. I tic-tacked with her family, the care home and her GP by email, and we instituted community palliative care. And so she died in her care home, in her bed at 4 o'clock in the morning with her family present, with Irish music being played. And I think as a testimony to the care we all managed to give her, they have actually given us funding for a renal counsellor and psychologist for 3 years out of her bequest. So I think this is an example of where non-dialysis was a good choice. So our final case, and again the palliative team were involved here, is of a 75-year-old man initially referred to us in 2010 when he was 70. At this point he elected to choose hemodialysis as his option, had an AV fistula created, and started to come to see us in the low clearance clinic in 2013. So our low clearance clinic is a clinic where we have patients who have kidney function, in or around 15 to 20%. And at that clinic we have a multidisciplinary team, including dialysis nurses, our counsellor, our dietitian, our vascular access nurse. And in fact, probably the only person who's missing from that clinic is a palliative care specialist. Probably not feasible with what Stephen's timetable is at the moment, but something to look for in the future, because it would give us the whole gamut of treatment options for a patient who comes between choice and non-choice of dialysis. So his wife passed away in 2014, and this was really the sentinel event here. He had a significant period of low mood following this. He had no family supports, no children, and he was living alone. We started hemodialysis with his consent in 2015. And within about 3 weeks of starting dialysis, he came to see me to say, look, I don't really want to continue hemodialysis anymore. It makes me feel miserable. My wife is dead. I have nothing in my life to look forward to, and I'm losing the bones of 3 days a week by coming to dialysis. So we agreed that he would have a further time-limited trial of dialysis while we addressed his mood. And 3 weeks later, he again came to me, and I had come to see him every week to say, look, I've given this a go. I want to stop dialysis. So 4 questions, and I suppose they're meant to prompt me as much as anything. Was it appropriate to start this man on hemodialysis? How should we have addressed his initial request to stop hemodialysis? Was a further trial of dialysis reasonable? And how would you support this patient during cessation of dialysis? So any comments? Should we have listened to him the first time? Did we have managed his mood? Did we read him wrong? What do you think?
But it is obviously going to take time. So a therapeutic response to his mood.
Yep.
And also, if you feel that needs to be addressed, you seem prepared to make informed decision making.
Okay, so when I discussed this case at another forum, it generated some really interesting comments. I have a really strong belief in the primacy of the patient and their right to choice, and even if their mood is low, I still think they have a right to choice. And some of the hemodialysis nurses fed back that I had to continue to dialyse this patient because it was the right thing to do, and couldn't countenance the idea that a patient who appeared to be physically well would choose to stop dialysis. We had a very interesting discussion. So after his first conversation with me, I referred him to our counsellor, really to ensure that we were providing him with all the supports he needed around his decision making. I reviewed him each week on the dialysis unit to assess his progress. I felt that my role and the role of the nursing staff supporting him was to empower him to believe that it was entirely his right to continue or stop dialysis, and that he could return to dialysis within a certain time frame if he elected to stop and then decided, you know what, I've changed my mind. But that time frame is pretty tight, because really if you leave it more than a week to 10 days, people have entered the terminal phase. So I supported him through his second decision to stop dialysis. We had already a care plan drawn up with the patient, his primary care team in the community, and palliative care. Because he had quite good native function and he still passed quite a lot of urine, we had to factor that into our predictions, and so it was likely that he wouldn't die within 8 to 10 days and might live a little longer. So he went home, he had palliative care visits weekly, and at week 4 at home he was admitted to the hospital electively, and he entered his end-of-life care pathway there. So really, within 2 months of starting dialysis, this patient had died, initially under our care and then finally under the care of the hospice. And I have to say, it created a lot of distress with our dialysis nurses at the time, who had never had a patient who had chosen to stop dialysis at such a short time frame. Okay, so to get into the talk proper, there is what a lot of nephrologists still espouse as the traditional model of renal care. And you notice that on the left-hand side here of your screen, there's one little box that says conservative management, which basically means that if you don't have dialysis, well, we're not really sure what we're going to do with you, but we'll put you in a little box and we'll call it conservative care. I now actually call this active medical management, because I think by including the word active, patients and other staff feel that you are still doing everything apart from dialysis. So most of the focus of a nephrologist is, of course, on renal replacement therapy, which is for some patients preemptive transplant, but for most patients planning for dialysis access, transplant workup, and ultimately the choice of hemodialysis or peritoneal dialysis. And about 90% of our patients choose hemodialysis, 10% choose peritoneal dialysis, which is a home option, and probably 2 to 3% of our patients choose conservative care. So this is the current model of renal care, and you'll notice that it's a continuum where for very few patients we actually manage to cure their kidney disease and they get discharged from our follow-up. The majority of patients have kidney disease for life, and they die either with or because of kidney disease, and probably half of our patients die with a functioning transplant. In terms of dialysis, I think it's really important for anybody who looks after a patient with end-stage kidney disease, or anybody who is required to consult on these patients, that dialysis is not curative. For selected patients, maybe about a third of our patients, it's a bridge to transplant. It's life-prolonging in selected individuals. It may not improve quality of life. In fact, if you poll dialysis patients, 70% of them will report pain at some point within the previous week. The symptom burden would be comparable to the symptom burden of patients with cancer, and there is a very significant treatment burden. And when we look at data, particularly in regards time lost to hospital visits, transport to hospital, time in the dialysis unit, patients would say that they factor in that they lose at least 50% of their week to dialysis. And a lot of that is not feeling great before dialysis and recovering after dialysis. So it remains an extraordinary means of prolonging life, and it produces an extraordinary burden for patients and their carers. So prognosis is the Holy Grail. And you would think that nephrologists who dialyse patients and look after people with end-stage kidney disease would be good at identifying patients who are deteriorating and would be very good at prognostication, but actually we're rubbish at prognostication. So I always say that if we wait until there's incontrovertible evidence where it's completely obvious, there's irreversible decline, or the patient's deteriorating with no possibility of stabilization or improvement. And I think this probably rings a bell with you as palliative care consultants and support team, because I would suspect you're tearing your hair out when you come to see patients who are in this situation. By that stage, the patient will be dead. So I put this slide up for my own team to challenge them to think about their patients, because when you look at a patient 3 times a week, you don't always see those subtle changes that indicate that you need to be thinking about care planning the needs of the patient and the family, and that you need to be having conversations with patients about what their care wishes are. So end-stage kidney disease is universally fatal without renal replacement therapy, but prognostication is difficult. We virtually never discuss prognosis with our patients. So if I see a patient who's 35 in the clinic and I talk to them about starting dialysis, I probably don't tell them that they have maybe an 80% chance of being dead in 10 years without a transplant. And you would ask me, well, why don't we prognosticate? And there are a couple of factors. First of all, we genuinely don't always know how people are going to do. Think the view of the clinician as a paternalist. We think our patients don't want to know. Now that may be real and that may be perceived. A lot of clinicians actually have a core difficulty with prognosticating for their patients. And then some clinicians have ethical issues around giving people that sort of bad news that makes it harder for them to engage with their treatment. But I think for us, the real issue is that there's a very small number of validated prognostication tools. There are 1 or 2 tools that would predict the patient who might die within 6 months, but nothing is validated beyond 6 months. So in terms of survival with end-stage kidney disease, I usually quote that we would probably have replaced our whole hemodialysis unit within 7 years. So there are very, very few people that make it beyond 7 to 10 years in the dialysis unit. So they're remarkable individuals if they do. So if you actually look at survival rates for bowel cancer versus lung cancer, patients with end-stage kidney disease straddle those. So they do better than patients with lung cancer, but they do worse than patients with bowel cancer. And I think when you consider that, you know, why aren't our palliative care services much more intimately involved with these patients from earlier on? And why is it that it comes as a surprise to us that our patients die? So why do they do so badly? You know, is it because we're bad at our job? No, it's not. It's because renal disease rarely exists in isolation. Most of these patients have concomitant cardiovascular disease. At least half of them are diabetic. The patients that we're looking after are getting older and older. We are now offering dialysis to far more marginal candidates because patients want it, or maybe because we don't explain properly what the price of dialysis is. And I would challenge you to say that actually only the survivors make it to dialysis. So when you come to the dialysis unit and you see our patients who are falling apart, these are the best patients, because the patients who make it to dialysis are the patients who don't die of cardiovascular disease. By the time your GFR hits 15, you're 15 times more likely to actually die of a heart attack or a stroke than you are to ever make it to dialysis. So that tells you how tenuous the health of our patients is. So this is a slide taken from a New England Journal paper from 2005. And the reason I still use this slide is the statistics have not changed. And actually there should be a new line right at the bottom here, which is if you're over 80 and you start dialysis, the chances are you'll be dead within 12 months. So I know I'm preaching to the converted here, but I suppose I put this slide in to remind myself of what the function of palliative care is. So palliative care, the WHO definition from 2014, is that it's a multidisciplinary approach to provide holistic care to address physical, psychological, and the spiritual needs of patients and their caregivers. So it's primarily focused on quality of life and symptom management. It's not intended to either hasten or postpone the death of the patient. It can be applicable at any time point within the course of a patient's illness, and it's not prognosis dependent. And I think, as Marie, Siobhan and Stephen will testify, they get a lot of referrals in Tala from the renal team, and they are not always about end-of-life issues. In fact, we rely on our palliative care team particularly around symptom management, in particular pain management for patients who may not be dying, you know, maybe 6 months, it may be a year, but because they have the special skill set to address these needs within our patients. And so many of the patients who dialyse in Tala are not afraid of the concept of palliative care, because we tell them it's palliative care, but we tell them that it's for symptom management because we cannot manage the symptoms that they have. So there is an acceptance that palliative care may dip in and out of their treatment as required. So in terms of the model of palliative care, the reason that I gave you that preamble is that we really firmly believe that palliative care should be intertwined within the treatment course of our patients, which is why I'd like to integrate them more into our clinical services. And to that end, one of our nurses is actually completing her training in palliative care, and I'm hoping to get funding to actually allow her to provide palliative care for renal patients, obviously complementing the palliative care services that are in the hospital. In terms of how much palliative care time our patients eat up, the WHO recently, within the last 2 or 3 years, had a very important publication in BMJ where they identified that probably less than 10% of people who needed access to palliative care worldwide ever access palliative care. And if you look at this pie chart here, probably about 0.5% of the workload of palliative care comes from patients with end-stage kidney disease. So there is a massive unmet need throughout the world for palliative care, and I would suspect there's a massive unmet need within our own end-stage population for palliative care. So how do we recognize the last phase of life? So as a nephrologist, how do I know that I need to be thinking about end-of-life care? How do I recognize that the patient is potentially entering the last 1 month, 3 months, 6 months of life? So we do use these tools in our monthly MDT meetings. We use the surprise question pretty much on a monthly basis now. So every month we discuss our patients. It's a multidisciplinary MDT where we literally fly through the patients and we kind of throw it out there. Well, how's this patient doing? Would you be surprised if they died? And in fact, we don't use the year. We use the 6-month surprise question. And we've developed a kind of a risk register of people that we feel we need to really keep a closer eye on in terms of family supports, counsellor, social work, and palliative care if required. We do look at certain prognostic factors: age, dementia, frailty, falls, nutrition, and particularly peripheral arterial disease. So once our patients start to get non-healing leg ulcers, or once they start to have amputations for peripheral arterial disease, the majority of them will die within 6 months. In terms of the symptom burden for our patients in the last phase of life is really significant. Pain, agitation, and dyspnea would be the principal symptoms. So you probably use much more subtle tools, but in terms of the utility of the surprise question, there are about 5 or 6 papers that have addressed its utility in patients with end-stage kidney disease, and it's a really simple premise. The idea is that you ask the patients you ask the nurses or staff who best know the patient, would you be surprised if this patient dies in the next 12 months? And in our unit, the people that we rely on are the nurses who dialyse the patients. So really we use this for hemodialysis patients and a little less frequently for our PD patients. So a hemodialysis patient is in hospital 3 times a week. So that is 3 opportunities to assess that patient in terms of how they're doing. So very simple study from the States, 150 hemodialysis patients in 3 dialysis units, and the nurse specialists within the units were asked to answer the question. So for about 20% of the patients in the unit, they said, you know what, we wouldn't be that surprised if they died within the next year. And 30% of those patients were dead within 1 year. For the 80% of patients where the nurses staff said, yeah, we would be quite surprised if they died within the next year, 10% were dead within 1 year. So basically, for one simple question asked repeatedly, the odds ratio of dying was over 3-fold higher. If you ask the specialist nurses looking after those patients, do you think these patients might die? So where could we use the surprise question? So at the moment, we use it on a monthly basis in our MDTs. And our MDTs, as I said, are multidisciplinary. They're not led by the physician, they're actually led by the nursing specialists. The purpose of using the surprise question is to identify the high-risk patient, but mainly to act as a trigger to assess patients further for advanced care planning, focusing on quality of life and symptom management, and considering referral to palliative care within the hospital. So we're very lucky in Tallaght. We have an amazing palliative care team. We've had superb SPRs over the years, and actually we've collaborated on a number of research projects around palliative care in our patients. So within the last year and a half, Lynn Redahan and actually Bernadette Brady, whom you know, published a paper looking at end-of-life care, a retrospective review of end-of-life care over 5 years of all patients whom we looked after who'd actually died under our care. And there were 172 deaths in patients with end-stage kidney disease over that time. 70% of these patients were on hemodialysis, 20% were on peritoneal dialysis, and 12% of deaths occurred in transplant patients. So what we found over that time was over the last year of life, these patients spent almost 2 months in hospital. So you would think that we would have realized that they were dying, and they had on average 3 admissions. And for those who chose to stay with us in hospital, the mean time to death was 23 days. So not surprisingly, for patients where a decision to withdraw dialysis was made, so obviously that refers to our hemodialysis and peritoneal dialysis patients, all of those patients had a referral to palliative care. But as I said, most of them chose to stay in hospital to die, and that's because of the long history that we have of looking after these patients. Now, some of the reason that the death took place in hospital is that we can't always access palliative care in the time frame that we need it in terms of transfer to the hospice, because our patients tend to die quite quickly after dialysis is stopped. So for the 105 patients where a decision wasn't made to withdraw, some of these patients were sudden and unexpected deaths, but none of those have been referred to palliative care. Therefore, none of them would have received probably best quality end-of-life care, but a certain cohort of those would have died at home from sudden death, and sudden death from cardiac disease is relatively common. It probably accounts for 20% of all deaths with our patients. So you can see that a very small number of our patients were transferred to the hospice. And again, that is not because we don't value hospice care, but it's because patients and their families frequently elect to stay with us. So the other thing that they did was they looked at the time from referral to palliative care for our patients versus patients with malignancy and non-malignant disease. So the time from referral to death for patients with renal replacement therapy was typically in the order of 12 days. And that's not too surprising, because when you withdraw dialysis, most patients will die within 8 to 10 days. For patients with a malignant diagnosis, the time from referral to death was in the order of 40 days. And for patients with other non-malignant conditions, the time to death was under a week. In terms of opioid and sedation use within the last 48 hours of life, for patients who were known to palliative care, 80% of patients would have received opioids, and over 2/3 of patients would have received appropriate sedation. Whereas if you compare those figures to patients not known to specialist palliative care, about 70% received opioids, and fewer than half of patients received sedating medication. Again, a slightly crude marker, but indicating that by not referring to palliative care, potentially there was suboptimal management of these patients. So what did we learn from this actually? Well, what we learned from this study was to identify referral triggers and that we had missed opportunities for referral. We also identified that the expertise for managing these patients was actually, we do have a lot of good skill sets ourselves in terms of identifying and managing these patients, and that it was an opportunity to upskill our own nurses, which is why one of our nurses is doing palliative care training. I would exercise caution around complex drug handling. Our patients do funny things with drugs, so you need our input as much as we need your input at end of life. We learned that the patients frequently chose to stay with us, but we also learned that we needed to put earlier end-of-life care planning into place and to consider advanced care directives. So what do our patients die from? Death from uremia only occurs in about 25% of our patients, and that is either because they choose to withdraw from dialysis or because dialysis is not offered or declined on the part of the patient. So 75% of our patients die still on dialysis, and the principal cause of death would be cardiovascular disease, and some of this is sudden death at home. Infection accounts for 25% of death, and sudden death, as I've outlined, would be 25%. So the breakdown is 50% known cardiac death, 25% infection, and 25% sudden death. So, excuse me. In terms of cessation of dialysis, it is very important for patients, their families, and the medical and nursing staff looking after patients, that you can predict when patients are going to die. We've had one or two situations where we have said to families, look, we think they're likely to die within 7 to 10 days. And 4 weeks later, the patient and the family are still looking at us going, well, what's happening here? So although we can prognosticate reasonably accurately, the one caveat is if patients have good residual urine output with a couple of mils of function, they do live for a little bit longer, and you need to factor that into your prognostication, because it can be somewhat embarrassing when your families are going, well, how much longer? And I'm not in the business of hastening death, but actually it's the 3 or 4 weeks later, and they're sitting up in bed going, Dr. Wall, you said it would be over in 8 to 10 days, and I'm still here, and well, what's happening? Now, that's fantastic, but actually you do get carer fatigue. The patients get a little tired. They're going, I was ready, I'm still ready, and nothing's happening. But in general, most of our patients die within 8 to 10 days. Most of them will slip into semi-consciousness within 5 to 6 days following cessation of dialysis. And one of the very, very, I suppose, important things for families is that we tell our families once the patient slips into unconsciousness, they are not going to wake up again, and that's very important for families. So in terms of recognizing the terminal phase, and this is relevant obviously for us as kidney caregivers, but also for anybody else who comes to see the patient. The diagnosis of the deteriorating patient and the dying patient can actually be difficult, because there are some reversible causes of deterioration. Sepsis, hypercalcemia, opioid toxicity can present in a very, very similar fashion, and if you treat them, the patient may recover and live for a little longer. But the features that we rely on that indicate somebody really is approaching the terminal phase would be when they become bedbound, when their level of consciousness starts to slip, or when they're semi-comatose. Now obviously it's burned or obvious when they're semi-comatose. But patients who have difficulty with nutrition, so when we get to the point where they're managing sips of fluid or their oral medications with difficulty, and when they have poor tolerance of renal replacement therapy. And actually one of the challenges that we have with not patients but with their families is that they feel that if we talk about stopping dialysis, that they are withdrawing an active treatment and that we are allowing their family member to die. And when I talk to them, often the patients are already manifesting difficulties with dialysis, so they're finding it hard to tolerate their full duration of dialysis. The classic sign is dropping blood pressure on dialysis, or the patient who's hypotensive at the start of dialysis. So these are warning signs that mean we can now start the conversation with the family. And often when I talk to families, I couch it in the fact that, they're no longer strong enough to sustain the dialysis treatment. So we're not asking for your permission to stop dialysis. We are telling you that this person's body can no longer sustain the treatment that we're offering them, and we're actually harming them or bringing them to the dialysis unit. And that takes away a lot of the guilt that family can have when they are involved in the dialysis withdrawal decision. And I should also say to you that as much as possible, it's the patient that I try and engage with around withdrawal dialysis. I have a real issue with families saying you can't tell the patient, you can't tell them you're stopping dialysis, because it's pretty bloody obvious when the patient's not going to dialysis and they ask you, am I not going to dialysis today? So this is where you can have a little bit of aggro with the families, but most of the time the discussions that we have are with the patient, unless there's such an acute deterioration that we don't have time to have that discussion. So in terms of the symptoms that we manage and the symptoms that you help us to manage, I think number one symptom would be pain. I think the second symptom is around fear and anxiety, fear of death, but actually fear of shortness of breath would be a really big concern for our patients, because it's drilled into their heads that if you don't have dialysis, fluid is going to build up in your lungs and you're going to become short of breath. So that's one of the huge things that we need to address very early on with our patients, to tell them that we will not allow them to suffer shortness of breath, or if they do become short of breath, we can and will do something about it. Nausea, itch, agitation, confusion, delirium, myoclonus and twitching. These are all of the sorts of symptoms that patients develop and that we need help to manage. So how do we manage pain? So I know paracetamol is on the pain ladder, and I must be a little bit cynical, but I often think giving people paracetamol is like giving them Smarties. Now I know you'll come back and say that's not true. It's got a very, very valuable role. But for me, looking after a patient, I would much rather get in with a potent drug at a very low dose to give them decent pain relief than to be messing around with mild drugs and building them up to a crescendo. Now, we do use non-steroidals. There's an expression in our unit which I coined, which is that diphenine is the devil. And it is, but actually there is a very important role for NSAID use in terminal care. When we use non-steroidals, we do ask that you weigh up the risk of bleeding, because patients who aren't being dialyzed and uremia itself, they are bleeding risk factors. So we don't really want somebody who's known to have significant peptic ulcer disease bleeding out in us because we've given them a non-steroidal. And we would also remind you that people who have residual renal function, that non-steroidals will significantly diminish that. So you have to weigh up the benefits and the risks when you're prescribing non-steroidals. But it is incredibly effective for bone pain, joint pain, pressure ulcer pain, and inflammatory pain. And in fact, we have used it in syringe drivers with the help of palliative care for managing terminal ulcer pain in patients who are dying of peripheral arterial disease or calciphylaxis. In terms of neuropathic pain, which is probably present in about a third of our patients, we use pregabalin, we use gabapentin, but I'm putting a big health warning on these drugs. They are renally excreted, they accumulate in end-stage kidney disease, they accumulate even more markedly in patients who aren't being dialyzed. So you have to start at the lowest dose possible. For some patients, that's an alternate day dose as opposed to a daily dose. Top them up after dialysis, but be aware of the neurotoxicity with these drugs. So I had a patient who was put on pregabalin 50 BD. She went home and 2 weeks later she was brought into ED and she was doing this. And she couldn't walk because they accumulate and they cause myoclonus. So they are really important in the armamentarium of symptom management. But if you are using them, you start at the lowest possible dose and you up titrate maybe every 3 to 4 days. Now, Dr. Higgins and his team are fully aware of this, but I would just put it out there for the rest of the palliative care service that they are drugs that come with a significant health warning because of their accumulation. They are very effective, but you need very little of them to work. So in terms of non-steroidals, I do want to talk about this a little bit more. Non-steroidals are nephrotoxic, okay? So if you have a patient who comes to you in clinic and they've got bad gout and they have a creatinine of 500 or 600 and they don't want dialysis, you would probably give them an NSAID for 2 or 3 days to manage the acute episode, but you would prefer not to continue it long term. The other thing that you need to know is that they can cause very significant salt and water retention, and they can precipitate pulmonary edema. So in a patient whom you are not dialyzing, precipitating pulmonary edema is a disaster. So again, the health warning, use for a very short period of time and instruct the patient to use it for no more than 2 to 3 days and then stop. The GI side effects will be enhanced in patients with uremia because they're already at risk of uremic gastritis, but we do allow occasional use. Now, when I issue a prescription for an NSAID, they're available over the counter, but actually what I usually write on the prescription to the pharmacist is do not dispense over-the-counter NSAIDs, only dispense on prescription. But it's quite difficult to put a control on things like ibuprofen. So in terms of opioids, which we do use a lot in our patients, just to remember that a large number of these opioids are renally excreted and they need to be used with caution. Morphine, diamorphine, oxycodone, codeine, dihydrocodeine, they're all renally excreted, and certainly their active metabolites are. And the active metabolites can cause very, very significant CNS excitation. And the issue here is that you have a patient who's in pain, who's a little bit drowsy, and you then give them a relatively high dose of an opioid to manage their symptoms, and you get paradoxical excitation and agitation, and that is very, very difficult to manage. So we do use opioids, but again, what I would ask for people who aren't used to renal patients is start at really, really low doses and titrate very slowly. So probably anywhere between 1/5 and 1/6 of your usual dose. Increase the dosing frequency maybe to 8 hourly rather than 2 to 4 hourly. assess the patient on a really regular basis for signs of accumulation, and only titrate every 2 to 3 days. So in terms of the preferred opioid, our preferred opioid would be fentanyl or alfentanil. We do have a bit of an issue because it's quite a pricey drug, but I think that we have managed in Tala to persuade the anaesthetists and the pain management team that the only drug they use in a syringe driver for pain management of patients who have surgery now for our patients is fentanyl, which is a huge improvement. And certainly we would rely on fentanyl patches and fentanyl syringe drivers under the supervision, ideally, of palliative care for end-of-life or difficult care pain management. There are no active metabolites that we need to worry about in terms of excretion. They're predominantly hepatically excreted, so obviously care patients who have liver disease as well. There's a little bit of accumulation in end-stage kidney disease, but it's not an issue. And the other drug that Stephen and I have used very occasionally would be methadone. And in fact, we had one patient whose ulcer pain we couldn't control, and actually he was transferred to the hospice for 2 weeks to titrate his methadone to manage him. Methadone is a very, very tricky drug. It's hard to titrate. The effect is unpredictable, but it can have a very important role in neuropathic pain. I would say here, I will never use this drug. This is definitely a palliative care drug only. So in terms of how we manage dyspnea, it's common and it's multifactorial. There are some very practical issues. Nurse the patient sitting up, give them supplemental oxygen. Use diuretics at very high dose if they have native urine output. And although we stop hemodialysis, there are times when we will give patients something called isolated UF, which is where you bring them to the dialysis unit and you maybe take off a litre of fluid over an hour. You're not dialysing the patient, you're not prolonging their life, but you're managing their dyspnea. We use opioids and sedating medications very, very frequently for the management of dyspnea, and certainly anti-secretory medications as required. In terms of anti-emetics, cyclizine is first line. There's no dose reduction required. We would usually use it in a syringe driver over 24 hours, 150 milligrams, and the sedating effect is very useful. Metoclopramide crosses the blood-brain barrier. Significant risk of extrapyramidal tract side effects in our patients, so if you're going to use it, 50% of the usual dose. Domperidone, or as that's referred to in our unit, domperidone, is used at full dose. Prochlorperazine, no problem, but the drug that we mostly rely on would be nasonin. And I suppose we use it increasingly because as well as its anti-emetic role, it's got a fantastic sedating role. So it would be very commonly included within syringe drivers for end-of-life care of our patients. In terms of delirium and agitation, very, very common as uremia progresses, and actually probably the most distressing symptom for families when they come to see their patients. For mild delirium or hallucinations, we would use haloperidol. Then for worsening delirium, certainly in the terminal phase, either midazolam or nasonin. I think I'm preaching to the converted here, but I have to tell my own team this all the time. You do not use opioids to sedate patients. If you use opioids at high dose to sedate patients, they will get agitated. So we tend to go with low dose opioid with a benzodiazepine in our syringe driver. So in terms of what else is important, communication. It's all about communication. It always was with our patients. In terms of the patient frequently will want to know how and when they will die. They will want reassurance about symptom management. For families, we need to tell them that the delirium is not reversible and it's a sign of ongoing physiologic decline. Once they're effectively sedated, these patients will not wake up. We explain to them that the medications we use may well hasten the process of dying, but they are used to ensure symptom management and comfort. We find that our families often resist sedation, even in the terminal phase, because they want to be able to talk to the dying person, and the dying person is distressed. So that's something we need to overcome with good communication. And one of the biggest issues that we face is families' concerns around denial of therapy, particularly around dialysis and around IV fluids. So we have to very carefully explain that actually we don't give IV fluids because our patients rarely experience thirst in the terminal phase, and because many of them are anuric, they actually maintain a good fluid balance without dialysis. So I'm nearly there. In terms of the goals that I think we should have as a nephrology palliative care interface, the development of care pathways with palliative care. Now, we have an amazing palliative care service. We have a really good relationship. We probably ask them to do a lot of stuff that maybe they don't do in other hospitals because we rely on them so much for symptom management. But I think those care pathways will allow for earlier intervention and advanced care planning, and more home or hospice deaths if we were to have the conversations with patients earlier. In terms of training, it's now a mandatory module of the SPR training for nephrology, and that's something that I introduced when I was an NSD. I think there's huge value in cross-specialty training, the idea of holding combined study days for palliative care and nephrology, and also enhanced training for the specialists in our service. So, why aren't we beating your door down to refer our patients to palliative care? Well, there are a number of barriers. The disease has an unpredictable trajectory. When you're talking to the patient, they have uncertainty about their prognosis, as does their caregiver. There is, for some patients, a distrust or a misinterpretation of the role of palliative care, and I'm really careful when I talk to patients. I explain what palliative care is, but very often I couch it in saying, we're not asking them at this phase to talk about end-of-life care with you, but we need their help for symptom management, and it would be very rare for any of our patients to refuse palliative care input. Many of our patients lack understanding of the severity of their disease, and as caregivers, we focus so much on active management that we forget about the other components of care. In terms of access to palliative care, it's not always adequate. There are hospitals who have difficulty accessing palliative care. That's not the case for us. And in terms of the clinical team, there is a concern about taking away hope if you engage in palliative care. I don't actually support that view. We tend to overestimate our patients' survival. We focus too much on the active care. Some of us have huge difficulties discussing end-of-life care with our patients, and some of us have difficulty parting with our patients, what I call transition of care. So in summary, renal palliative care is significantly neglected in nephrology. It's under-resourced, and I think for many of us it's a low priority in our day-to-day work. We have difficulty devolving care. We've been so actively involved in these patients for so long that it's quite a wrench for us to give them up. We do need an increased focus on palliative care and end-of-life because the patients we're dialysing are older and sicker. More of our patients are choosing to withdraw from dialysis, and more of our patients are choosing non-aggressive management. And finally, the importance of focusing on both quality of care and quality of dying. Thank you.